This is Charles Denham. I have the honor of opening our webinar for this month, the TMIT National Research Testbed webinar, The Opioid Crisis, New Threats to Caregivers. This is our 104th month in a row of undertaking such a webinar, and we've picked this topic to interrupt the series on sepsis because it's such a crisis to first responders, caregivers, emergency medicine physicians, and folks in the clinics. And so because of this dire crisis, we thought we would interrupt our series on sepsis, which will resume next month, but we thought that this was a very important topic to address. I just want to ask all of you to make sure to get your audio up and go on your computer if you're not getting good audio and turn up your WebEx volume, your computer volume, and your external speaker volume to make sure that you get good sound. I'm on slide 4. If you don't have good sound, then you can click on participants and then click on the icon for request phone, and we'll give you a direct phone line. I'm on slide 5 for those that have slides, and those that don't have slides, go to www.safetyleaders.org. In the upper right-hand quadrant, you'll see what's new, upcoming events, and click on the Opioid Crisis, New Threats to Caregivers, and that'll take you to a landing page where you can go ahead and log on. And this page, in the future, will have more resources on it and more detail regarding what we're covering today, because this is such an important crisis. On slide 7, and there you can download the slides if you don't have them. If you wish to follow us on social media, it's on slide 7. I won't belabor that point. And I'm on slide 8, and just address our purpose statement. So our purpose of Safety Leaders and TMIT and the National Research Testbed is to measure our success by how we protect and enrich the lives of families, patients, and caregivers. And the caregivers are really a critical issue on this opioid crisis and all the new agents that are coming down the pipe and new exposure issues. Our mission is to accelerate performance solutions that save lives, save money, and create value in the communities we serve and the ventures that we undertake. Our disclosure statement is on slide 9, and there are no product, services, or technologies for which any of us have any financial, primary, or secondary interests. We will hear today from Dr. Gladstone McDowell as our primary and longest speaker. We'll also hear from Dr. Christopher Peabody in emergency medicine. Dr. McDowell is a pain medicine doctor, board certified in 4 specialties and an expert on the opioid issue. And then Dr. Boats, who is a professor at the MD Anderson Cancer Center. Arlene Salamandro is our patient advocate, and we'd like to ask Arlene just to set our focus and make sure that we have patients and families and the caregivers' interest at the center of what we do. Arlene, could you open us?
I just want to thank everyone for being here today, for joining us on this webinar. Opioid abuse is a growing problem in our society. More and more I hear about this in our neighborhoods, all the way from the rural areas to the cities. So I'm very concerned. We're all touched by this epidemic. And I'm really glad that we're having this because I think we all need to learn more. And as a patient, it's very important that we know a lot about this and we can pass that information on to other people to protect themselves. And especially to our caregivers, they're right on the front line, and I think it's very important for them to be informed on this growing problem. So thank you, Dr. Denham. Back to you.
Thanks, Arlene. So the first thing that I'm going to do is just address what's in the news and our webinar survey update from last month to tell you about your colleagues and what they responded to in the last month. However, I also am including slides, and Kyle Kemp, who is our leader and chief of staff in Austin. Kyle, I'm going to ask you to put the slides up, the majority of the slides up in a PowerPoint format so that you can address your constituencies, those of you that are safety leaders that need to address this key issue. So we're going to put the slides, not just the PDF, but we'll, by Monday, have the slides up for you as well so that you can use the slides for your presentations in this crisis. So we asked the question last month, we made the statement, I am interested in more detail on opioid overdose and drug diversion issues, and we had a 66% agreement. However, just since last month, this has become an increasing crisis because there are naloxone-resistant strains of fentanyl that are being used, and we've had more first responders and emergency medicine technicians have respiratory arrest due to exposure to some of these dangerous this dangerous material. We have asked you for a free text entry, as we always do, on the topics that you want us to cover. I think most of these we have covered because the speakers have reviewed them. However, we're going to give you the chance also to add more to them, so I'm not going to read the list. We ask you whether you wanted continued input on sepsis. We've had a two-part series, and we had tremendous response. We had over 700 organizations last month on sepsis, and so sepsis Part 3 will be next month, where we're going to sum up Parts 1 and 2 briefly, and then have more focus on it. It appears to be an area of very, very high interest, and you can see 72% of you gave it a 10. So even if we have to have a 3-part and a 4-part series, we'll ask you each month whether you want more. You've given us a lot of detail that you'd like us to cover, but today for time, I won't read this, but you can look at the slides. Our speakers for next month on sepsis Part 3 and sepsis Part 4, if we have one, will address all of the issues you brought up. And you can see that there are 2 slides of content that we have there, and so we definitely listen to your free text entry, and we will definitely address all of these issues. We also ask you, when we fully complete our sepsis series, what future webinars would you like us to cover? And you've given us ample focus: violence in healthcare settings, respiratory failure prevention, the MDROs, HCAPs, recovery of patients after surgery, readmissions, and a number of topics. Again, I'm not going to bore you by reading that. So basically, over the last 2 years, we've been doing an incredible amount of research. We've been doing primary and secondary research on all of these topics you see here. The 7 leading causes of death of children and college-age folks, but also workforce years. It turns out that these 7 areas are areas for which normally healthy people are having major issues and patient safety issues when it applies to bystander care. So we have developed after-school programs. Last month we finished our first summer school program for older kids. We'll have in fall a family program, and law enforcement and security officers we're doing in September. So we now understand that this is a critical issue, and opioid overdose is one of those focus areas. We've broadened our focus from just bystander care in the golden 10 minutes before EMS arrives, which you see in the donut in the lower left quadrant, and then above that, pre-hospital EMS care. What can we do to help the first responders as they are getting our patients from an accident site or a site where something, anaphylaxis or a major trauma may have occurred, but then also how to follow through the hospital definitive care, and where are the breakdowns in patient safety? One of them is in return precautions, and so we're addressing this entire continuum for those conditions. So that brings us to our topic today, and what's happened is that we can now see that an extremely small volume of fentanyl, which is the middle tube that you see there, that the amount in that bottle is enough for an overdose. The amount in the left bottle is enough heroin for an overdose. But carfentanil, 10,000 times the strength of heroin and morphine, is what is used to tranquilize rhinos and elephants. Both fentanyl and carfentanil are being mixed in with heroin to make more money by the illicit drug pushers. It is being developed in countries offshore. It's being sent through the mail. It's hard to detect it in the mail, and you can have 50,000 overdoses in a typical first-class envelope. So the problem with fentanyl and carfentanil is respiratory suppression, and now we have this problem that has shown up with our officers. So on slide 22, this is an assemblage of slides that we have prepared for you in the past. And again, Kyle, we're going to ask you to post these as slides so you can copy and paste and use this information. But as recently, as today, we have the issues regarding the deadly nature of these substances. Police officers are getting overdoses after brushing fentanyl off their uniforms. They are getting transdermal absorption, this very small particles, so that one really needs to now start to be using safety glasses and N95 or better masks for filtration. So some of these slides you all have already seen. I'm not going to read them for you. I want to provide them as assets for you as you give your presentations and try to help everyone in your organizations. It's also critically important to know that your security officers that are oftentimes the folks that discover someone with an OD in a parking lot, and now that many of our hospitals have been acquiring physician practices, you're technically and legally responsible if you're charging hospital fees in an outpatient environment to have the safety precautions be at the level of your acute care hospital. So you see you see fentanyl can sicken first responders, and then carfentanil is the tranquilizer or is what is used for elephants and rhinos are now showing up. And what you really need to know, and as you go through these slides, and now I'm on slide 24, is 2 new strains of fentanyl are showing up that are refractory to naloxone, meaning that Narcan will not work on them. And so what's critical is you've got to get somebody in to a location where people can manage the airway and intubate the patient and respire for them until it wears off. So this is absolutely critical, and the transdermal absorption of these substances is absolutely critical. So on slide 25, more slides, and we recommend that you review these articles. And Carl, I'm going to ask that these articles all be posted for you as well. On slide 26, you can see the issue of police. Now we're working with security and police officers. Sorry, you're hearing a little noise in the background. And here, working from my home office, and I've got 2 golden retrievers working with me. But we have this fentanyl is absolutely deadly, and we have security officers and police departments working now to come up with better guidelines to address them. So on June 25th, since our last webinar, the epidemic is so extreme that even librarians are being trained to use Narcan because they're seeing overdoses in libraries. There's a stat projection of opioid overdoses could kill more than 650,000 Americans in the next 10 years. This was released since our last webinar. These are new slides. I'm not going to go through them for you because Dr. McDowell will address a lot of the data, and he has a pretty data-rich presentation. The makers of oxycodone and Percocet are being sued by the U.S. over the opioid crisis. This New England Journal of Medicine article addressing the fentanyl threat to public health is an excellent article for you to reference because of how we all really admire and respect the New England Journal. And this graphic, and you can see the source at the bottom of the slide, addresses any opioid versus heroin, and then the other synthetic opioids, and you can see the climb of the numbers of the synthetic opioids and what an incredibly steep issue we have going. Another thing in the news was this recent fraud takedown, and we're starting to realize fraud is just at crisis proportions in healthcare for many, many reasons. However, it's interesting to note that of the 412 people charged last week or week before last with the largest bust in healthcare history, that 120 defendants, including doctors, were charged in their roles in prescribing and distributing opioids and other dangerous narcotics. So we've got a problem. The more of us, the more organizations that hire doctors and medical clinics now have a risk, a threat to the organization. And on slide 33, you see those as well. So you'll be able to use these slides to address the fact that this is crisis proportions. Congress is now involved also in the opioid crisis. It's something to really address. Now, when we go back to the medication use process, and we've used this slide over and over and over again with the great work that's been done in medication management, and we look at the harm that can be delivered with unintentionally or intentionally by those bad actors in delivering medications and prescribing medicines. When we look at prescribing errors, these numbers are all going to change with opioids because we have such a major problem, and we have this very difficult ethical issue going on with a lot of practitioners. The 5 rights of pain care was something that we put forth years ago, Dr. McDowell and I, to then take the positive tack. Let's see what we could do to manage pain in a positive way, and he'll conclude with this slide as well. The right tests, the right diagnosis of the pain and the pain generators, the right treatment that is not typically short-term narcotics that might be cheaper and more approved by the insurer, but are there other things that we can do, healing touch, acupuncture, muscle strengthening, and a number of different issues, monitoring the improvement, and then the right prevention so that the patient doesn't get back in the same boat. And you'll hear from Dr. Peabody that'll address the responsibility of the caregivers, especially emergency medicine doctors, who've realized that they may be part of the problem with short-acting agents. So we're right on time at 15 minutes after the hour. That's your introduction, the background of the slides, and these slides will be available to you, and we'll have Dr. McDowell's slides being available to you not only as a PDF but also as PowerPoint so that you can use them. And with that, we'll ask Dr. McDowell to go ahead.
It gives me great pleasure to introduce Dr. Gladstone McDowell. He has been a long-standing and wonderful national leader in pain management and is addressing this critical opioid crisis, which is a new threat to caregivers. He's the medical director of Integrated Pain Solutions in Columbus, Ohio, the director of our task force and our MedTech opioid leader at TNIT, and has spoken numerous times to our audience and done a terrific job. He will be setting up the problem for us and helping us understand what's going on, but also be concluding with best practices for caregivers now that the threat of these very dangerous substances is increasing to caregivers and the public. Gladstone?
Thank you, Dr. Benham. Good afternoon, ladies and gentlemen. To begin, I just would like to discuss the scope of the problem. So this slide shows you the drug overdoses by state, and I'm sure that you can see your states represented here. Interestingly, you see a large amount of drug overdoses in the Washington state area. And as we go on to discuss one of the newer illegal substances that's really plaguing us, I will discuss a potential connection to the Washington area. The Centers for Disease Control, in looking at national opioid deaths over an extended period of time, we can see that back in the early 2000 area, when we started using a lot more of the long-acting opioids, the number of deaths from prescription opioid pain relievers began to increase. This all started with the OxyContin era and the hillbilly heroin use in some of the southern and Midwest states. We have followed this very, very closely. You can see that the breakdown between males and females. And unfortunately, the number of deaths from opioid pain relievers has been increasing each year. There are many efforts underway by not only the federal government and law enforcement, but all of the medical associations in trying to curb some of this by coming up with new guidelines and algorithms and significant compliance programs. This is a very important slide that shows you several facts. Let me just go through them. Fact: opioid overdose is a leading cause of accidental death in the United States. It actually exceeds gunshot wounds and traffic accidents. Fact: almost 4 opioid overdose deaths per hour are occurring, and most are preventable with Naloxone. Fact: opioid-related harm has had an explosive growth, as I discussed earlier, with prescription pain medications, unfortunately, as the gateway. Fact: the over 55,000 lethal overdoses in 2015 are as many youth as attended 73.5 U.S. high schools. Prescription pain relievers cause over 35% of our lethal drug overdose deaths, and that's very unfortunate. In fact, in a typical high school, approximately 25% of students are at risk for opioid overdose. We see that 80% of heroin users start with prescription pain medications. We know that at times some of these people were not able to afford the medically prescribed medications for a variety of reasons. To heroin, because we know that heroin actually turns into morphine in the body and provides analgesia for patients. In 2012, 259 million opioid prescriptions, which are enough to provide every U.S. adult a bottle of pain medicines, were prescribed. In fact, oxycodone is 30 times more addicting than heroin, whereas alcohol is 2 times, marijuana 3 times, and cocaine 15 times. In fact, patients diagnosed with prescription opioid abuse, dependence, or overdose occur approximately $11,000 per year more care is provided to them than people who are non-prescription opioid users. The cost of the U.S. prescription opioid epidemic is estimated at $78.5 billion. When we look at the ASA and the American Society of Addiction Medicine, addiction facts and figures from 2016, we see that of the 21.5 million Americans who are 12 years or older who have had a substance abuse disorder, and again, this is in 2014, 1.9 million had a substance disorder involving prescription pain relievers, and over 500,000 had a substance disorder involving heroin. And again, I've already discussed the potential association between heroin and prescription pain relievers. It's not always, unfortunately, in all of our practice, we've seen patients who have lost insurances, and the person has informed them that they can obtain analgesia with heroin, and patients will often go and try it, but as we know, you can't try heroin one time. You often become dependent and addicted to it. Overdose deaths and prescription, we see an upward trend from the 1999 to 2008. The overdose death rates, sales, and substance disorder treatment admissions related to prescription pain relievers have increased in parallel. The overdose death rate in 2008 was nearly 4 times that in 1999. We see that sales of prescription pain relievers in 2010 were 4 times that of 1999. And the substance use disorder admission rates in 2009 were 6 times that of 1999. So, I think we can see here that everything starts around that 1999-2000 time period when there was an increase in prescription pain prescriptions. 1 bottle of opioids per American. In 2012, 259 million prescriptions were written for opioids, which is enough for each American to have their own bottle of pain medicine. 80% of heroin users started with prescription pain medications, as we discussed. As a consequence, the rate of heroin overdose deaths nearly quadrupled from 2000 to 2013. In this 14-year period of time, the rate of overdose with heroin showed an average increase of 6% a year, followed by a larger increase of 37% per year in the 2010 to 2013 time period. 94% of heroin users moved the needle due to expense. When they looked at patients in the rehabilitation centers, they chose to use heroin because prescription opioids were far more expensive and harder to obtain. Unfortunately, almost 500,000 adolescents in 2014 were non-medical users of pain relievers, with 168,000 of these having an addiction to prescription pain relievers. We discussed that the heroin use is high and it continues to grow. An estimated 18,000 adolescents had a heroin use disorder in 2014. And when people have prescriptions for pain medications, they often share their unused pain relievers. They're unaware of the dangers of non-medical opioid use. And therefore, we see that most adolescents who misuse pain relievers, they're obtaining these either from a friend or a relative, and they're obtaining them without paying for them. One of the things that we realize with this whole prescription epidemic is that we cannot control the medicine cabinet. And this is why all of our efforts at compliance training and really limiting the dose and numbers of medications prescribed to patients are very, very important. We see the prescription medication use doubling. The prescribing rates for prescription opioids among adolescents and young adults nearly doubled from 1994 to 2007. Women are more likely to have chronic pain and are more likely to prescribe prescription pain relievers. We see that they are likely to be given higher doses and may use them for a longer period of time than men, and unfortunately may have a higher dependency rate. We've seen 48,000 women die of prescription pain medication overdoses between the 1999 and 2010 period. So their death rate doubling time is greater than men. The slide from the American Society of Addiction Medicine just graphically illustrates that time period that I discussed with you from 2010 to 2013, where the heroin use increased 37% per year. We see all drug overdoses really increased exponentially from the 1999 to 2014 time period. In 2010 to 2013, the heroin-related overdose deaths increased by a whopping 270%. Prescribed medications account for nearly all overdose incidents caused by prescription pain medicines. I often tell my patients that most of the drugs on the street now come from patients. They're not from addicts, they're not from dealers, but they are unfortunately from patients who either don't manage the medications that they have at home, or unfortunately decide to trade, sell, or give them to other people. Opioid addiction statistics show as many as 3 out of 4 people abusing prescription drugs obtain them from a friend or family member. So what we have is that 80% of the prescriptions coming from 20% of the prescribers. The majority of prescriptions come from primary care and internal medicine. We do see quite a few from surgical specialties. Very few pain prescriptions actually originate from the small amount of pain specialists in the U.S. 80% of them do come from more of the primary care and surgical colleagues. If you look at also the Washington State study, it shows that the Medicare enrollees accounted for 45% of the overdose fatalities in the state. We unfortunately see the highest overdose deaths in the New Mexico, West Virginia area, with rates in these states being 5 times more than that in Nebraska, the state that had the lowest rate in 2008. Since 1999, the number of overdose deaths from pain medicines has increased by 3,000%. 3,000%. 4 million patients used heroin once in life. This is data collected by the National Institute on Drug Abuse. And of this number, an estimated 23% became addicted to the drug. From 1999 to 2010, sales for prescription pain relievers to hospitals, doctors, and pharmacies increased 4-fold. By 2010, the number of pain medicines prescribed was enough to keep every single American medicated for 1 month's time. In 2009, the abuse of prescription painkiller drugs accounted for almost 500,000 emergency room visits, and this represents a 2-fold increase in the drug-related emergency room visits compared to 2005. So what we have is 12 billion people using pain medications for other purposes. First-time abusers, we see 2 million in 2010. An estimated number of people reporting abusing pain medicines for the first time. This number amounts to 5,500 people a day abusing prescription pain medications first time. I'd just like to segue here to talk about heroin. So we discussed the fact that some people were introduced to heroin because they could not afford or obtain their analgesics that they were using for pain. Heroin use is a part of a larger substance abuse problem. So nearly all people who use heroin also have used at least one other drug. This is actually a slide from the Centers for Disease Control that I have used in speaking to high school and student groups, basically talking about gateway drugs. Most people use at least 3 other drugs. Heroin is highly addictive opioid with a higher risk of overdose and death for users. So people who are addicted to alcohol are 2 times more likely to be addicted to heroin. Marijuana, 3 times more likely to be addicted to heroin. Cocaine, 15 times. And you can see prescription opioid pain killers are 40 times more likely to be addicted to heroin. Now, in responding to the opioid epidemic, there are 3 simple things that we have recommendations from the CDC. First, prevention. Reduce the prescription opioid painkiller abuse. And I think all the medical groups, individual physician practices, state medical boards are making valiant efforts to reduce the prescriptions provided to patients while still balancing good patient care. So we are going to improve the opioid prescribing practices, and we're stratifying people into low, medium, and high risk. We're employing urine drug screening, tablet counts, and prescription monitoring programs to really try to reduce the prescription painkiller abuse. We'd like to reduce the heroin addiction, and one way is to ensure access to medication-assisted treatment plans, and certainly it is our hope that whatever happens with our healthcare system, that access to these treatment programs will not be affected. We need to treat people addicted to heroin or prescription opioid painkillers with these medication-assisted treatments, which combine the use of medications such as methadone, buprenorphine, or naltrexone, along with counseling and behavioral therapies, which are extremely important. We'd like to reverse the heroin overdose, but expanding the use of Naloxone, which is a life-saving drug that can reverse the effects of the opioid overdose when administered in time, and we'll talk a little bit more about this. I wanted to introduce sort of the concept of, these are the opioid classifications. So the only 2 naturally occurring opioids are morphine and codeine. Everything is synthesized from that. I won't go through all of them, but I'd like to touch on fentanyl here. So fentanyl is a synthetic opioid, and you can see that we have the semi-synthetic opioids, which are often the short-acting opioids that we use for acute pain and should not be used in their immediate release form for chronic pain. But fentanyl is actually a very common drug used in the anesthesia world, but also in the pain medicine world. Fentanyl is approximately 100 times more potent than morphine. And this is a drug that's often used during induction for anesthesia, and it's used in the topical and oral and sublingual form for pain control. Sufentanil is used in anesthesia also. It's approximately 1,000 times more potent than morphine. Now, with both of these drugs, you can reach your peak analgesic effect fairly quickly, which is why they're very good drugs for use in the application of anesthesia. In the pain world, we use these transdermal patches that provide the sustained relief of fentanyl for generally 72 hours. We very rarely use it in cancer patients at the 48-hour interval. There are some buccal medications that can be applied. There's a sublingual spray. There are buccal tablets. There's a soluble buccal film. And then there is a lozenge that you swab along the buccal mucosa. All of these applications are used for generally cancer pain and work very well. The topical medications can be used for cancer and non-cancer pain. So the reason that fentanyl works very, very well is it's a highly lipid-soluble medication and rapidly crosses the blood-brain barrier. The half-life is 3 to 4 hours for both fentanyl and fentanyl. And we always follow, the way that the kidneys and liver function when prescribing medicines, and we make dosage adjustments based upon the patient's metabolic state. Unfortunately, what we have is there are many analogs of fentanyl that have been used and abused. there is the omnifentanyl, the aquafentanyl, and the carfentanyl. Now, carfentanyl is only used legitimately as a tranquilizer for large animals such as elephants, but all of these are significantly more potent than fentanyl. These are not used for human medical care currently. Carfentanyl is approximately 10,000 times more powerful than a comparable dose of fentanyl, which is 100 times the potency of morphine. If you look at a vial size, so the vial on the left will show you the small amount of medication that is required to overdose from heroin. You see a small amount from fentanyl and you see a very small amount from carfentanyl, and this just reinforces the potency of carfentanyl, which is not used by medical professionals for human use. With the rise of the illegal non-medical fentanyls, it's really forced the police and investigators to change how they work. We saw the rise of things like carfentanyl and the other analogs of fentanyl really came into this country through the British Columbia area, and you saw some spread into the Washington state. The Canadians deal with this early. They have made significant strides and really set up a very structured program that the U.S. has borrowed some recommendations from. But one thing that we see is that now law enforcement and investigators really need to have protective gear like the Tyvek suits or air purifying respirators, or at least use the filtration masks. These should be used when contact with sweet fentanyl is suspected. Remember, it's a highly fluid medication, and contact with the skin or the mouth should be prevented. Naloxone, which is a drug that reverses overdoses, should be readily available, and all responders trained on how and when to use it. One thing I want to stress is that naloxone is a antagonist agent that will only temporarily reverse the dangerous adverse effects of opioids, and therefore further medical attention should be obtained immediately. Patients who are narcotized from the opioids who have a reversal with naloxone can become re-narcotized and still have respiratory suppression from this. And so if you administer naloxone, you should also be calling 911 to get help there, or immediately transporting the patient to preferably a tertiary care facility or emergency room where management professionals and tools are readily available. So let's talk about best practices. So when you're caring for opioid overdose, if you are a first responder, try to remember some of the following best practices. Exercise extreme caution with any suspected opioid delivery method. So if you're not sure, wear gloves, have one of those filtration masks available when responding to any situation where you suspect that carfentanyl or illegally produced fentanyl is present. If possible, cover as much of the skin. Wear long sleeve shirts, wear nitrile gloves, and then we also recommend utilizing the respiratory masks. Be aware of any signs of exposure. So these symptoms would include respiratory depression or arrest in a patient, extreme drowsiness, or profound exhaustion, disorientation, sedation, and then visualize the pupils. If they're pinpoint and patients have clammy skin, these are all signs of potential opioid overdose, and the onset of these symptoms may occur within minutes of exposure, especially with these fentanyl products. This will be your first clue to immediately not only protect yourself, but to also call 911 or get the attention of other medical professionals, because these patients will often require immediate medical attention. So carfentanyl and the other fentanyl-related substances can work very, very quickly. So it's important to seek medical attention. Any needle stick should be medically evaluated as soon as possible. If you are applying or utilizing Narcan or naloxone for these patients, please remember that will only provide a temporary reversal of the opioid effect. And unfortunately, there is some evidence that some of these fentanyl analogs do have a higher resistance to naloxone than fentanyl does. Do not touch any potential drug materials or area. So we know that fentanyl, again, is very lipophilic, can be absorbed through the skin, or there can be accidental inhalation of airborne powder, or some fentanyl does come in the liquid form, and you want to avoid the splashing into your eyes or coming in contact with other mucosal membranes. Avoid contact with needles. Do not examine bags if you can, or other paraphernalia. And be cautious not to come into contact or disturb any powder that may be in the area. Be ready to manage patients' airway in the event of exposure. So we talked about the fact that there's significant respiratory depression with this. They can override the body's breathing reflex, causing the victims to suffocate. While naloxone is an antidote for opioid overdose, it may not be available. Most responders are ACLS certified, and providing breathing assistance could help prolong the patient's life while waiting for emergency medical services to arrive. Even if naloxone is available, again, we know that this is only a temporary reversal. We want to send the overdose victim to a hospital for monitoring and potential life-saving interventions. The naloxone may wear off before the effects of the opioid, making it possible for the victim to re-narcotize and stop breathing again. So, Dr. Denham has talked about the 5 rights of pain care in the past. I think it's appropriate to discuss it here in that we, as physicians, take a patient, perform a history and physical, and obtain all the data that we can. We want to make the right diagnosis, and so what we do is we choose the right tests to assist in coming up with the right diagnosis, and then utilizing everything that we have at our fingertips to evaluate and make decisions on a subjective pain condition. We then come up with the right treatment for these people, and it often requires a multidisciplinary or multimodal strategy. Combining a team approach for this has really enormous potential for us to continue to do the right thing. And then we want to monitor these patients. We want to say, are we making an impact in your pain? Are we making an impact in your function? But also because we know that we do have a crisis with opioids and noncompliance, and unfortunately things like disability, we want to monitor these patients to make sure that they are utilizing the medication that we are prescribing, that we are the only ones prescribing controlled substances for them. We want to monitor their improvement or lack of improvement in function. And then, a big goal is to get people back to a more functional, satisfying existence for them. As a part of that, we need to adopt a more holistic approach by looking at what people do in their daily lives, looking at their ergonomics, looking at their jobs, and making suggestions or putting a structure in place to prevent re-injury or an exacerbation of a chronic pain condition. By doing all of that, I think we have respected the patient's right to pain care. We've done a good job in treating them. We also are being very diligent and responsible and not just prescribing opioids without a proper assessment and follow-up of these patients. And by doing that, we are contributing to the opioid crisis.
Well, Gladstone, thank you very much for a wonderful presentation and for doing this, addressing this crisis, which is really exposing our caregivers and the public and our young people to poisons that we haven't come across before. So, when we try to be a good Samaritan, it can put us and our families at risk, and out in the public, and those of us that are caregivers,
wouldn't you say that you'll probably see more guidelines regarding wearing eyewear, masks, gloves, and better best practices coming down the pipe? So we are very, very grateful that you've been able to give us a quick briefing while we wait for some of these formal recommendations with this exploding problem.
Yes, I absolutely agree, Dr. Denham, and I think that if physician inputs, actually all medical professional provider input is very crucial here, and I would like to just work more with law enforcement to try to come up with algorithms for evaluating these patients, and also making sure that we are not denying appropriate care to patients who need it because we are afraid of all the illegal uses of these medicines. There is a place for opioids, and again, you need to pick the right patient, right diagnosis, the right medication, and then you need to monitor these people. And so I think it's incumbent upon us as medical professionals to work with law enforcement and regulators to make sure that we're not denying care, but at the same time, we're being very, very responsible about how we make these controlled substances available. I've been saying this for about 10 years, but I think that unfortunately, particularly in the early days, because of the way that our insurance system was structured, short-acting opioids, which are not appropriate for chronic pain, were often on the lowest tiers and were affordable, and they could be provided to patients. The pharmaceutically long-acting and pharmacologically long-acting agents were more difficult to obtain because they cost more. So sometimes by these financial disincentives, some physicians would default to the short-acting opioids in their effort to provide pain control for some of these patients. And so I really think we need to look at everything, and the insurance companies need to play a part in this, in trying to make sure that we are able to treat patients' pain, but really minimize the types of medicines that do end up on the street and end up being abused by patients.
Well, thank you very much, Dr. McDowell. We really appreciate your help. And as soon as the formalized guidelines come down the pipe, we would love to have you come back and brief us.
Okay, Dr. Ann, thank you very much.
Great. Thanks, Don. So Dr. McDowell recorded that presentation this weekend. He is in the operating room today, but really thought it was a critical issue to cover. Our next speaker is Dr. Christopher Peabody. He's an emergency medicine physician and the director of the UCSF Acute Care Innovation Center. He's an assistant professor of clinical medicine. We've known Toph for a number of years. I met him when we were both at Harvard together. I was an advanced leadership fellow, and he was a Zuckerman fellow at the School of Leadership. And he expressed such great interest in patient safety, and we've worked with him since. He really believed that this is such a critical issue and recorded last night this presentation because he was doing a shift in emergency medicine, and yet he wanted to give you more than just a reaction to Dr. McDowell's presentation, which he listened to, and then I will do my best to click through slides of articles that he has provided, and again, we'll provide all these slides to you so that you can use them for your presentations. And with that, we'll let Dr. Peabody take it away.
Well, thanks so much for having me back. I'd like to be able to comment on the previous speaker's great depiction of what a crisis that we're in the medical community, also on keeping our caregivers safe, but also just to reflect a little bit on the role of the emergency department when it comes to opiates. I like to think about the emergency department as the place of service where acute care happens in the communities that we serve every single day. We do that at the Zuckerberg San Francisco General, where I practice, and in greater UCSF Medical Center here in San Francisco. We're seeing the effects of this opiate epidemic daily, not only in overdoses in an acute setting, but also in patients that are coming to the emergency department in need of management of their chronic pain. more in need of actually asking for help. What can they do when there is a problem? I see that in my patients. I also see that in their family members who bring patients to the emergency department and are asking for help because there is an addiction problem. So the emergency department is on the front lines and kind of all aspects of this crisis. Indeed, emergency department clinicians may even be part of the problem. There's a lot of research has gone in to show that the first step to a long-term opiate addiction is that initial prescription prescribed in the emergency department. So I'd like to take a couple of minutes just to reflect on my experience in the emergency department and then some of the programs that are going on across the country to address this difficult situation that we find ourselves in the medical community. Now, the Zuckerberg San Francisco General Hospital, where I practice, is the Level 1 Trauma Center for the city of San Francisco. And we're also lucky enough to be one of the poison control centers, or at least house one of the poison control centers near our facility for Northern California and the state of California. Members of our group recently published a study based off of patients that we saw in the emergency department. And I actually was the attending physician for one of these patients, and this happened about a year and a half ago. And this really illustrates, and anytime somebody tells me about the opiate epidemic and how dangerous some of these medications can be, and the medications in combination with each other, I always think about this case. And so I'd like to share that if it's possible. And I'll include in some of the notes a warning that our Poison Control Center kind of put out to the city of San Francisco and to the medical community at large. This was a case of a young man who had come in, which was found unresponsive by their friends after they took a quote-unquote Xanax. This patient bought Xanax on the street, and unfortunately for him, this Xanax was actually not Xanax. It was actually fentanyl cut with a benzodiazepine analog, meaning something like a Xanax, but with fentanyl in it. These two medications together can be a deadly combination. In fact, what we saw was that this specific combination of medication actually prolonged the effect of what we normally see in a fentanyl overdose. The effects are stronger with this benzodiazepine analog, and we saw really significant signs of opiate overdose, including peripheral neuropathies, shutdown of the kidneys, the rhabdomyolysis, and severe pulmonary edema, requiring more intubations than we normally would with an opiate alone. This combination of medications stemming from a single pill of this counterfeit Xanax actually caused a few deaths here in San Francisco, and this pill was actually found going around the country. And different emergency departments were reporting effects like this with substances cut with fentanyl or a benzodiazepine together, causing extremely dangerous situations for our patients. This is what I think about when I think about the opiate crisis, because it's real to me. It's something that I have to deal with clinically. This acute setting is not necessarily what is causing or driving the majority of the opiate crisis. These overdoses are a small percentage of what is a greater opiate addiction overall, and I think the last speaker talked to that very well. Now, when there's a national crisis, we see that in the emergency department. What I mentioned earlier was that, unfortunately, we know that the opiate crisis, in part, is caused by physician prescribing practices. There's even a recent article from the New England Journal of Medicine that even shows that there's a wide variation of the rates of prescribing opiates, even within the same emergency department. These rates of long-term opiate use were actually increased in patients who had not received opiates before, meaning that the rates of prescriptions actually matter. If we're prescribing things in the emergency department, this matters to our patients, and it has effects on whether or not they'll be taking opiates for long-term use in the future. Now, emergency departments throughout the country are actually dealing with the aftermath of this crisis. We see all the acute overdoses. We also see that even patients that we prescribed opiates to in an attempt to treat their acute pain can even end up as long-term users of opiates. So I think this is one of the reasons why emergency departments are actually becoming a little more proactive rather than reactive to this opiate epidemic, meaning that we're not just going to treat the aftermath anymore. We're actually going to be trying to become the solution proactively. And let me highlight just 3 things that emergency departments are doing around the country. Now, the first one I think most people know about, and that's prescription drug monitoring databases. Emergency departments are now adding these, checking these databases before prescribing opiates in a lot of instances. If someone has been having multiple prescriptions within a recent time frame, then the emergency departments are actually saying, listen, we have that hard conversation about whether or not somebody needs help with opiate addiction. Our emergency department, it goes a little bit further. And in fact, we've actually implemented a trial of actually prescribing Suboxone or buprenorphine right there in the emergency department, which even requires a specialized license. But these are the types of programs that we're going the extra mile for our patients right in the emergency department. Now, I think prescription drug monitoring databases are great. I do believe that they are very cumbersome for caregivers that are trying to provide care in an efficient situation. There's one study that looked at the Massachusetts database and showed that it takes about 4 minutes for a clinician to log on and about 50 clicks before they actually find the relevant information about their patients. So as far as we can have better developed decision support tools for using this type of monitoring system, I think we're going to have better outcomes in busy settings such as the emergency department, and actually being able to use these prescription drug monitoring databases to their full potential. The second program that I'd like to talk about that emergency departments are using throughout the country and that we use at San Francisco General when it comes to the opiate crisis is actually giving patients naloxone. Now, there's a CDC guidelines about prescribing opiates, and it actually has an entire section in its checklist about prescribing naloxone. But we go a little bit further, and in that every single patient that comes to the emergency department for an acute overdose, whether it be drugs that were obtained on the street or drugs that were obtained in the prescription, we're actually giving in hand naloxone to these patients. Meaning you do not leave our emergency department without naloxone and naloxone training by our pharmacist or physician before you leave. And in this way, we believe that we're keeping patients safer. Now, the last thing and last program that I'd like to just hit upon here, if I may, is that emergency departments and emergency physicians are actually looking for alternatives to opiates. And one of the more famous alternatives to opiates programs was actually started in St. Joseph's Hospital in Paterson, New Jersey. And there's been a number of different lay press articles about this, including one in the New York Times. Essentially, emergency physicians are looking for different ways to treat acute pain, including renal colic, acute low back pain, acute headaches, extremities or fracture and dislocation pain, with different methods that have equal or superior analgesia or actually have better patient outcomes, but don't actually use opiate medications. Now, for example, a femur fracture can be treated with a regional nerve block and decrease your opiate use right in the emergency department. An acute headache, for an example, can be treated with something like Compazine and IV fluids rather than going straight to an opiate medication. Now, this isn't to say that emergency departments should stop prescribing opiates and bend over backwards and look for every single alternative, but what it is saying is that there could be a role for ED-specific protocols for specific diagnoses. And that's what they're doing in New Jersey, and they seem to be having some great effects with this. So these alternatives to opiates are happening in the hospital setting themselves, and they're also happening for when we're actually sending patients home. There are many other innovative programs related to outpatient prescriptions and how we can do that in the emergency department, having opiate prescription policies and actually trying to decrease the variability among emergency physicians when they prescribe opiates and when they don't. And I'm excited about all of these different types of programs. These are just 3 examples of what we can be doing in the acute setting, because essentially what we have been doing is being more reactive to the problem rather than proactive. And I'm really proud of the emergency medicine community for coming together to be more proactive about this opiate crisis that we see every day. Thanks, Chuck, for the opportunity to talk to you guys, and I look forward to your questions.
So we're very appreciative of Dr. Peabody for, he's on a shift right now, and whenever there's a chance that somebody may be called away, we pre-record it for you so that you'll have a good message and we won't have any speakers drop out. We're so grateful to he and Dr. McDowell for doing that, as well as Dr. Greg Boats, who's up next as a reactor. All 3 of these physicians have committed to help us as soon as more guidelines come out of protection of the caregiver. As you saw earlier, the Homeland Security Indiana website had a very good update. We've been watching the DEA and the hazards calls that have been going out to chief security officers of MD Anderson and others. We're very grateful to Chief William Adcox at MD Anderson for keeping us in the loop on those. And that brings us to Dr. Greg Boats, who is the professor of MD Anderson and the chief medical director for the UT Police Department. And we've recorded him today because of his duties at ICU and not sure that he could come on board. He's listened to Dr. McDowell's talk, and he's going to react to it, but he's also going to address his unique perspective. Go ahead, Kyle, roll the tape. Now it's my great pleasure to introduce Dr. Greg Boats. Dr. Boats is a professor of anesthesia and critical care at the MD Anderson Cancer Center, as well as an adjunct faculty member at Stanford University Medical School. And we've asked him to react to Dr. McDowell's presentation and address some of the unique perspectives that he has as a medical director of a police department and some specific topics that are critical new threats that can increase the risk to your caregivers and patients. Greg, first question is the role that you play as a medical director for a police department and what that has offered you regarding your perspectives.
Well, thanks, Dr. Dunham, for the opportunity to participate in this very important discussion. As a medical director for a police department, I have a little different perspective in that I am very worried about the health and safety of our law enforcement officers who interact with people who may have exposure to these ultra-potent opioids. And we're having to work on risk reduction and risk mitigation strategies to try to keep them safe while they're doing their business and trying to protect our society.
The second question is the increased threat and risk due to medication or drug diversion.
Well, our focus in this work is on patient safety and on caregiver safety. And I think one of the vulnerabilities caregivers in our very stressful work environment is the potential for diversion of controlled substances for personal use. And I think we have to acknowledge that because of the availability and access to these medications, a certain number of our caregivers are going to experiment or divert these medications. They're very familiar with their use in patients with chronic pain or acute pain following injuries or surgical procedures, but maybe not aware of the potential risks to themselves with self-administration. I think that this vulnerability is another dimension of risk that we need to consider when looking at the threat spectrum in healthcare.
Right, and also as people have adopted this behavior, they may be both diverting and as well may be utilizing some of the illicit substances. Is that a fair statement?
That's very fair to say. I think in previous webinars I've told the audience that in my 25 years in anesthesia practice, I've lost 5 friends to overdoses. And so this is a very real issue to me and to the people that I work with, the people that work as a team to care for our patients. And this is a very threatening area that is a significant risk to vulnerable providers. And I think the experience has been that once they get involved with these medications, it's very difficult to stop, to get back on the straight and narrow without some dependence on these very, very dangerous drugs.
Thank you. And now as we talk about the increased exposure to the threat of these substances, many of our hospital systems are acquiring physicians' offices, outpatient clinics, and heretofore facilities that may not have had a patient safety procedures and that kind of thing. And now they'll be required to provide the same level of safety as the hospital to both the patients and the caregivers. Do you want to ask this increased exposure risk to these substances in that scenario?
Absolutely. It's clear that there's a significant risk and vulnerability to our facilities and to our caregivers in new care models. We have undoubtedly increased our exposure in pre-hospital care and in outpatient care to persons who have either drug dependency or acute drug intoxication. And there's a significant risk with these ultra-potent opiates to come in contact with those patients. And just like we've seen in examples of law enforcement being exposed to very small amounts of these powders or agents and having signs and symptoms of acute intoxication, the same risk exists for our caregivers that may come in contact with people who have those substances on or about their body.
And so, Greg, the next question is regarding the evolution of these substances now with fentanyl being used to cut the morphine and carfentanil and these new strains that may be refractory to naloxone.
I think that's a tremendously frightening aspect of this opioid epidemic that we're seeing is that the fentanyl that's being introduced into the street drugs is literally killing thousands of people because of its potency. More frightening to me is the fact that drugs like carfentanil that are 10,000 times more powerful than morphine are being introduced in the community and having very significant impact on users. Another dimension that we hadn't really considered was the chemical alteration of these opioid drugs in the chemistry lab in order to change their physical and biochemical context. Some of the new drugs like acrofentanyl or furanylfentanyl have such high avidity for the opiate receptors. In other words, they're more sticky and not as easily displaced from the opioid receptors by naloxone, the reversal agent, but now even very, very large doses of naloxone won't reverse the respiratory depression and bradycardia associated with these medications. That is even more frightening to me because our ability to save people, once they get right of boom, is now being impaired because of biochemical alteration with an intention to cause harm to people.
This is really scary. I agree with you. And then the final question is, you brought our audience up to speed on the issue of the legalized marijuana and what's happened in some of the states now that there is, to some degree, a misinterpretation of what of dosing, and that a marijuana brownie may be thought to be
the same size as a regular brownie, and yet there are up to 4 doses for the same volume. And we're seeing this now showing up in schools with children buying these products over the dark web and actually bringing them to school. Can you address kind of where we are with these with this problem?
Well, it's certainly a very concerning development as we move towards more and more state jurisdictions allowing either medicinal or recreational marijuana use and consumption. What we're seeing is that novice users of these agents fail to understand the potency and the, in fact, increased potency of these drugs over time. And it's very easy for them to overdose and have very bad psychological or physiologic consequences to such large doses. The problem with THC, the active ingredient in marijuana, is that it's very slow onset. And so, as opposed to other drugs where you get an immediate physiologic response or feeling of high, it's not so with these edible opiates, and people don't recognize that maybe one cookie or one brownie has more than one or perhaps as many as 8 doses included, and they'll continue to consume until they start to feel that high. Well, by the amount of THC they've ingested is very, very high. And we're seeing reports of emergency room visit and very significant psychological consequences of ingestion of such high concentrations of THC. I'm worried that will continue as the availability to school-age children increases in these jurisdictions that have recreational use.
Well, Greg, we're so grateful for bringing our attention to this with the MedTac program and the fact that we can actually get kids up to speed on the overdose issues. And you helped us understand that this is even something at the University of Texas where students were bringing forth their concerns. This issue of having Narcan availability, you want to just finally just address, how critical that we have this available to us in the public?
Well, I think we've spent a lot of time working on the prevention side and the reaction to some of these health threats and vulnerabilities. And Narcan is clearly a safe shot. It's something that can be used to reverse the respiratory depression associated with opiate overdose. And more groups are finding that their populations are vulnerable and the threat to their population is at increased levels, including schools, universities, social groups. Absolute need for Naloxone in those environments to save someone who inadvertently overdoses is critical to try to improve their survival. We see that almost 60,000 Americans died last year from a preventable death, and those from an opiate that may have been either reduced in impact or prevented entirely with the use of Narcan to reverse respiratory depression.
Well, listen, you have been so generous with your time, and we just all want to thank you for helping develop the concept of the MedTac program and the Care Huddle to help us have some of these emergency competencies become available in the community. Thanks very much, Greg. We certainly appreciate it.
It's my pleasure.
So what we would like to do now is go to our national survey and ask you all to respond, as many of you as possible. Are you interested in more detail regarding opioid-related best practices for caregivers, care of your patients, but also protection for your own staff? And then what topics would you like on the webinar is the free text entry second question. So the first is if you very strongly agree, we'd like to see a 10. If you very strongly disagree, a 1, and we will then take that information and go from there. Then the topics you'd like to have us cover, because we make sure that all of our speakers review exactly what our audience, what our community of practice really wants to see. The second question is, you're interested in more regarding caregiver diversion. So diversion of medications and compassionate care of the caregivers who are involved in diversion, and how we can work better with HR, with risk management, and with our security folks to be less prosecutorial and more, and get what we would call left of boom. Get ahead of this issue and try to reduce the opportunity for actually having a drug diverter move from one hospital to your hospital or your facility. But then also, if you have one, how can this best be dealt with to keep your patients safe and keep your caregivers safe? And then the specific topics that you would like to address. Could you put that, please, in the section on the free text entry, which you see at the bottom of the slide now, and in the on the right side? What I'd like to do is, before we go to Arlene, I'd like to just draw your attention to the thought or comment that I had regarding the upcoming work that we're doing, and we'd like to invite you and your teams to be involved in that. The MedTech program is that we're growing very rapidly and taking it across the country, and actually been asked to take it to Europe as well. And the focus is on these three donuts. The bystander care, which is in the golden 10 minutes before EMS arrives or emergency services arrive. How can we train bystanders to address CPR for cardiac arrest, Heimlich maneuver for choking, how to deal with a near drowning patient, Narcan for the opioid overdose or poisoning and calling poison centers, for anaphylaxis, the EpiPen, major trauma. We're focused on the Stop the Bleed program, which was actually put forth by the Obama administration, and it continues to have support with the Trump administration to take tourniquet use and pressure bandages, wound packing, training out to the community. And then transportation accidents that are not traffic related. These are the drive-over accidents at home or at schools. And then bullying and workforce issues. So we're addressing all of those, and in September we'll be putting together the program, a much more comprehensive program. We've already started for security officers, SWAT team officers, first responders, your security guards, and what to do to address all of these, because they tend to be the first ones there before EMS arrives, and actually the police force tends to beat the ambulances, and there are an enormous number of lives that can be saved from bystander care. And we've been pioneering this in schools with after-school programs and summer school programs, and soon to be a family program as well. So with that, I'd like to then come back to Arlene Salamandra to react as a patient advocate. Arlene?
Yes, Chuck. I just love the presentation. The speakers were great. As a patient, I didn't understand that it was such a danger to the public if you try to help someone who is overdosing. So that's something I'm going to share with all my friends and family. And also, the source of a lot of these addictions comes from the medicine cabinet, sounds like. So I think a patient could do a lot to monitor their own medications. And also, if you don't use them all, for whatever reason, make sure that you could dispose of them properly, and maybe have more places for drop-offs, or in the pharmaceutical stores where you could get rid of these drugs. So very, very, very informative. I really want to share a lot of this information with everyone. Thank you.
Great. And so we have a number of questions that have come up and some comments. Pat Heinrich stated, this reminds me of the origin of the AIDS epidemic. People were fearful to help people, found help needing CPR for fear of self-injury. And I think that's such a good point, Pat. I think that we need to make sure that if we are going to help somebody, that we protect ourselves with gloves, and that we're aware of these issues, but be very, very clear of that. And we had a question regarding circumstances where hospitals were sued for infringement of privacy rights or Fourth Amendment violations when staff removed illicit substances. and that was submitted privately, so we'll find that answer out. Another question or comment was from Linda Egbert. In the context of prescription pain meds, what is your perspective on managing pain, acute or chronic, and how to balance it? And Linda, this is hopefully you've responded to the request for more on opioids. We're going to have Dr. McDowell come back and talk about the 5 rights of pain management and take a deeper dive into each one of these, the right test, the right diagnosis, the right treatment, the right monitoring, and right prevention. And we just need to make sure that the entire audience wants to see it. But if you can submit to our free text entry, that would be great. I think we have finished our webinar now, and we've got everybody covered. Our 3 physicians actually were called away, one to surgery, and Dr. Boats was on ICU call and was going to attend live if he could, and Dr. Peabody was pulling a shift in the ED. I want to thank those gentlemen, and we're so grateful that they are so committed to help you and your patients regarding this critical issue. I think just in summary, I think it's really, really important that we balance the fear with boldness for care, and just make sure that our folks are equipped with gloves, with masks, with protective eyewear, and be cognizant of the potential risk, but still be aggressive in taking care of patients. Because I think the point, was made earlier that I read as one of the comments, that this is not unlike the AIDS from Pat Heinrich. This is not unlike the AIDS epidemic, and we certainly don't want to avoid taking care of people. However, I think it's important that our children and our families are aware that if we come across someone that is unconscious, that we call 911 immediately. We're teaching kids how to make a proper 911 call that is composed of telling them what the mobile number is, what the address or location is, the rally point or some physical location where the EMS can come, and at least putting the patient in a recovery position. We, in our after-school program, in just the first 7 lectures, we saw the first life saved because the instructors were taught the recovery position, which is something that most of us didn't learn in medical school or nursing school. So we're very, very appreciative of everyone and your attention today. Thank you, Arlene, for representing patient advocates. And with that, we'll close our webinar, and we look forward to next month. We will address sepsis 3, our third in our 3-part series, and if we continue to have such strong interest to have continued deep dive in sepsis, we'll add a 4th. So many thanks, and God bless you, and we hope you have a great July and August.